Okay, I think I'm sure others will continue to join, but I think we have a good amount of people that have joined already. So we'll go ahead and get started. Um, Thank you, everybody, for joining this session of the the Targeted Neonatal Echo and Neonatologist Performed Echocardiography Foundations curriculum. On behalf of my co-chair, Gabriel Altit, and myself, we are extremely happy with how this curriculum series has been going, and we really do respond to all of your session feedback. So I do have the QR code up right now. I will put it up again at the end of the session, but feel free to please make sure you're muted. Thank you. So feel free to take it now or to wait until later, but it is important to make sure that you give us your feedback on those evaluations. So our regular kind of housekeeping stuff, make sure that you ask your questions in the Q&A if you are part of the big webinar. Sometimes those questions can get lost in the chat, and so we don't want to accidentally do that. The first session will be a lecture for about 30 minutes, and then there will be a breakout session for our hemodynamics trainees, where we'll do a case-based presentation. So we will go ahead and try to get started so that we can remain on time. And with that, let me introduce our speaker. So today we're going to be learning about the PDA. Aisling Smith is a consultant neonatologist at the Rotunda Hospital and Children's Health Ireland in Dublin, Ireland. In 2021, she completed a National Children's Hospital Foundation Health Research Board funded PhD encompassing prospective observational studies of myocardial function and pulmonary hemodynamics in various neonatal populations, including infants born with Down syndrome, infants conceived via assisted reproductive techniques, and infants born to mothers with gestational diabetes. Her research interests lie within these cohorts, as well as topics related to the extreme prematurity population, including low blood flow states, acute and chronic pulmonary hypertension, and the PDA, which is what she's going to focus on today. And so with that, I will hand it over to you, Aisling. Please take control, and we look forward to your talk.
Thank you so much, and thanks so much for the very kind invitation. Let me get my slides for you.
And just to reiterate, I'm sure you guys all know this, but for the panelists, feel free to jump in and ask your questions. You don't have to put them in the Q&A, but for the second session, we will not be recording. This session, we will be recording. Did you start the recording?
Indeed, we are recording.
Perfect. And we will stop the recording for the questions. Okay, great. Let's go.
So thank you so much again. This is a very large topic, but I will do my best to cover it in a decent way. So the talk outline, we will discuss the PDA anatomy, physiological principles, echocardiography evaluation of the hemodynamically significant PDA, some determinants of PDA closure, and then some cases. So I've just highlighted some important points with a light bulb, and these are particular learning points that I hope I convey across. So with regards to PDA anatomy, so we all know that the PDA is a fetal shunt. The ductus arteriosus is a remnant of the distal sixth aortic arch during fetal life, and it connects the proximal descending aorta to the main pulmonary artery. And it's located posterior to the aortic arch where it enters the anterior pulmonary artery. We also all understand and recognize that the PDA is a very dynamic structure. It has variable shapes, variable sizes, and variable lengths. And there's actually a classification system for the shapes of various PDAs. It can be conical, window, tubular, saccular, elongated. But in our line of work, the most frequent type that we will see is type F, or the fetal type. And this concept that the PDA is a dynamic structure is very important, because that has implications for how do we call a PDA hemodynamically significant, you know, what diameter matters, etc. So please remember that it's a dynamic structure, and this is why there may be differing measurements between different individuals when they're assessing it on echo. And actually, what's more important is the hemodynamic impact that a PDA might be having on the physiological state of the infant. And the diameter is one part in all of that, but it's not the be all and end all, because there's many other factors that could be at play with regards to its hemodynamic significance. For surgeons, an anatomical marker of the PDA is the recurrent laryngeal nerve, which loops posteriorly around the PDA and descends behind the aorta en route to the larynx. So as you can see here, this is the ligamentum arteriosum where the PDA would have been, and this is the recurrent laryngeal nerve which loops behind it. And this makes sense as to why historically, when there was PDA ligations being performed more frequently, now it's PDA device closures. This explains why this was often injured during that surgery. With regards to physiological principles, we understand that it's a fetal shunt. And in fetal life, oxygenated blood passes from the placenta to the right atrium, the right ventricle, and then the ductus arteriosus shunts that blood from the unoxygenated fetal lungs to the fetal body. And this makes sense because the placenta is obviously the site of gas exchange during fetal life, and you want the oxygenated blood and blood volume to be shunted to the fetal body to support its growth and oxygenation. And actually, less than 10% of fetal ORV output enters the pulmonary circulation because it's shunted away by the ductus arteriosus. Then at birth, a huge amount of physiological changes occur. The lungs fill with air. We have a drop in our pulmonary vascular resistance, an increase in our oxygen tension, and therefore a decreased blood flow through our ductus arteriosus. So in term infants, functional closure typically occurs between 12 and 24 hours of age after delivery, and anatomical closure in term infants typically occurs between 2 and 3 weeks of age. We also appreciate that there are many risk factors for PDA, for patent ductus arteriosus. And again, obviously the most frequent one that we would see is prematurity. So we understand that there's an increased incidence of PDA with a decrease in gestational age. But there are lots of other risk factors for a PDA, including low birth weight, respiratory distress syndrome, hypoxia, acidosis, sepsis, fluid overload, if a premature infant didn't receive antenatal steroids, high altitude, or a maternal history of rubella during the pregnancy. So a number of these could be at play to put our patients at higher risk for the presence of a PDA. We know that there's many clinical signs and symptoms of PDA. So the kind of classic signs are a pansystolic murmur, bounding femorals, a wide pulse pressure with a low diastolic blood pressure. But then it's also important to think about the consequences of a PDA, which could be pulmonary overcirculation or systemic hypoperfusion with a large left to right shunt. So from the context of pulmonary overcirculation and the clinical signs or symptoms you might see a patient with increased desaturation and bradycardic episodes or apneas, pulmonary hemorrhage. You might see signs of pulmonary edema on a chest x-ray with fluid overload, or that the patient is ventilator dependent. You can't wean the vent, you can't wean the oxygen, or you might not be able to extubate your baby. And then from the systemic hypoperfusion side of things, we understand that PDA is associated with an increased risk of developing intraventricular hemorrhage, necrotizing enterocolitis, and acute kidney injury because of that so-called systemic steal. Now, moving on to the echocardiography evaluation of a hemodynamically significant PDA. So the 3 ways that I like to characterize this is to look for those signs of a large left to right shunt. So what signs are there on my echo of systemic hypoperfusion, pulmonary overcirculation, and then the PDA characteristics itself? So first of all, I'm going in the order that I typically would do an echo in. So starting from the subcostal view, looking at the abdominal aorta and specifically looking at your celiac trunk and your superior mesenteric artery. So the effect of ductal steal on systemic perfusion can be quantified using echo, and we can use pulse wave Doppler assessment of our celiac artery. So we understand that the celiac artery blood flow falls in the presence of a PDA compared to controls, and this is despite a rising left ventricular output. And typically what we're looking for is our Doppler pattern. So in a normal situation, where there either is no PDA or else a PDA that's not exerting a large systemic steal effect, we will have preserved diastolic flow in our celiac artery, as in part A. If the PDA is becoming more of a problem, it's becoming more significant, the next step we'll start to see is absent diastolic flow in the celiac artery. And then in the worst and most severe cases, we'll actually see reversed diastolic flow in the celiac artery. And B and C are signs of at minimum, a moderate or even a severe PDA. And it's kind of the same concept as when the obstetricians are looking at the placental flow. You're looking at that sign of systemic steal. And obviously, if you're starting to see the signs of B or C on your echo, those patients might be the patients at an increased risk of neck or feeding intolerance because the blood flow to the bowel is getting compromised. So again, from our subcostal view, looking at the atria, obviously, if you have a hemodynamically significant PDA, you're going to have increased pulmonary venous return, and that over time can lead to left atrial enlargement. And again, further down the line, you might see a dilated left ventricle over time. But in the presence of your patent foramina valle, the left to right shunt across the atrial level will increase in the setting of a significant PDA due to the increased pulmonary venous return and increased left atrial pressure. So as you can see in this image here, there's quite high velocity flow across the atrial communication, and you can actually measure that as well on Doppler assessment. Next, moving on to the long axis parasternal view. As I mentioned, if you have increased pulmonary venous return into your left atrium, over time, your left atrium will dilate up. And one of the more objective ways to assess this is the left atrial to aortic root ratio. So the LAAO uses the relatively fixed diameter of the aorta to assess the degree of left atrial volume loading. So this is our long axis parasternal view with our left atrium, mitral valve, left ventricle, intraventricular septum, and our aortic valve. It's important that your marker is perpendicular to your aortic valve and your left atrium, and then you use M-mode to quantify this. So using M-mode, we calculate the left atrial to aortic root diameter, and this ratio correlates significantly with increased pulmonary flow attributable to excessive transductal flow. And typically, we would call a hemodynamically significant duct present if the LAAO is over 1.5. We can also look at our shortening fraction. So shortening fraction is a marker of left ventricular function and volume loading. And again, if you have increased pulmonary venous return into your left atrium and therefore into your left ventricle, you can become more hyperdynamic. You have a higher preload. So we can calculate our shortening fraction by measuring our left ventricular end diastolic diameter and the left ventricular end systolic diameter using N-mode and applying this formula here. And our normal neonatal values for shortening fraction are between 28 and 40%. So as you can see here, again, we're still in the long axis. It's important that your ventricle is fully open, that you have a nice long ventricle, and that you are putting the ventricle perpendicularly with your M-mode. And then you can measure your left ventricular end diastolic diameter and your left ventricular end systolic diameter and calculate your shortening fraction. And in the setting of a significant PDA, your left ventricular end diastolic volume, end diastolic diameter is increased because you have increased left ventricular volume loading, and the shortening fraction is often increased too because of that hyperdynamic circulation. Over time, you might see signs of mitral regurg if your ventricular annulus is also being stretched with the increased preload. But you can also get interesting and useful information from assessment of the diastolic filling patterns on pulse wave Doppler. So in the developing fetus and premature babies, the early phase of diastole, so your E wave, is less than the late active phase, your A wave, resulting in an EA wave ratio less than 1. And this is because in our premature babies, their hearts are stiffer, they have an inherent diastolic impairment, and that means that they're more reliant on their atrial kick than on the so-called passive filling. So that means that their A wave is typically larger than their E wave. But in neonates with a hemodynamically significant PDA, because you have that increased preload with increased blood returning to the left atrium, that actually will start over time to force open the mitral valve earlier, and you'll have kind of pseudo normalization of the EA waves. And your EA ratio may actually flip to being greater than 1. So I'll show those measurements to you in a moment. So here, so in a typical adult, for example, we do most of our filling in our early phase, and our atrial kick only contributes about 1/3 of our diastolic filling. So in adults and in older children, the E wave is larger than the A wave. In our premature cohorts, their normal state is the opposite, as I explained, because their hearts are stiffer. So they actually rely much more on their atrial kick and on their late diastolic filling. So their E wave is smaller than their A wave. However, in the setting of a hemodynamically significant PDA, it will pseudo-normalize and reverse, and the E wave will be larger than the A. And another measurement that you can use is the isovolemic relaxation time, which is also part of this same concept. The IVRT is the time between closure of the aortic valve and opening of the mitral valve, and is prolonged in the fetus and the immature neonate. But the IVRT will decrease in neonates with a hemodynamically significant PDA due to the early pressure-related valve opening from the increased preload. Now moving on to our apical view. So it's important to assess your left ventricular output. So your left ventricular output, you measure the mean velocity of blood flow across the ascending aorta from the apical 5-chamber view, and you acquire the diameter of the aortic root from the parasternal long axis view. And your left ventricular output will be expressed in mil per kilo per minute. And you can calculate it using this formula. And in the context of a hemodynamically significant PDA, your left ventricular output will significantly increase due to the increased left ventricular preload, but it does not usually translate to increased systemic blood flow because of ductal steal, because you're getting into a situation where the shunting, the left-right shunting, is actually causing pulmonary overcirculation with systemic hypoperfusion. So even though your left ventricular output is high, it's not translating to increased blood flow to your end organs. From the high parasternal view, it's important to assess your branched pulmonary arteries, and in particular, your left pulmonary artery. So the presence of diastolic flow in the left pulmonary artery is also a useful indicator of ductal significance. Specifically, a high-end diastolic velocity is representative of a large left-to-right shunt and increased pulmonary perfusion. So as you can see here in the Doppler pictures, A is in the normal setting where there's either no PDA or a small PDA, and you don't see any extra diastolic flow occurring. However, in the presence of a significant duct, you'll have extra diastolic flow in your left pulmonary artery and sometimes your right also. Again, similar to our discussions about looking at the diastolic flow in the celiac artery, you can look at the flow in the descending aorta. So from your high parasternal view, focusing on your aortic arch, again, looking at your diastolic patterns. So in the absence of a PDA, there's some diastolic flow in the descending aorta, as in A. In the presence of a hemodynamically significant duct, diastolic flow in the descending aorta can become reduced, as you see here in B, or in extreme circumstances, it can actually be reversed. And then, of course, we finally get to the PDA itself. So I hope it's come across that as you're progressing through your scan, even before you looked at the PDA, you can already be picking up a lot of evidence as to whether there is a PDA and its significance to the baby and to the physiological state, even before you echo the PDA. You've already gathered a lot of information as to whether the lungs are likely to be experiencing overcirculation or whether there's a situation of hypoperfusion systemically. So when we come to actually looking at the PDA, there's several things that are important to measure. So it's useful to have an idea of the architecture of the PDA. Like I discussed earlier, there's all of those different shapes. So it's helpful to know what kind of shape this PDA might have. You obviously need to do a diameter measurement. We need to take that from the pulmonary end, and we should be taking our diameter measurements in grayscale and not in color, because we could overestimate its diameter in color. It's obviously very important to apply color Doppler so that we understand visually the direction of blood flow. So we start to appreciate, is it a pure left to right shunt, or is there any element of bidirectionality, which would trigger other thoughts in our heads with regards to the physiology. And then, of course, it's very important for us to apply pulse wave and continuous wave Doppler to the PDA. And when you do, you might see any of these patterns. So this on the top left of this panel is a non-restrictive left to right flow. So that's a very open PDA. It's, as the name says, it's open and it's non-restrictive. Then if the PDA is becoming smaller and starting to close, you'll see a rise in the diastolic velocity and you'll have a restrictive left to right pattern. Bidirectionality, you'll see flow both above and below the line, and that will be flicking right, that will be flicking red and blue. And that obviously could be a sign of pulmonary hypertension with systemic, at a systemic level, or it could be a sign potentially of congenital heart disease. So very important to have done a proper structural assessment or engage with cardiology if you're not sure. And then the final panel here is pure right to left flow, a pure blue duct. Again, which could be suprasystemic pulmonary hypertension, or also important to assess for any evidence of congenital heart disease. So by the time you get to the PDA, you should have a pretty good idea as to what impact it's having on the physiology of the patient. But then these particular points are extremely vital to your assessment as well. And then the final thing, or one of the final things that's worthwhile having a look at, another marker of our systemic hypoperfusion state is our middle cerebral artery. So panel A, and the same as with the descending aorta and the celiac artery, you're specifically checking the diastolic flow. So panel A shows that there's positive diastolic flow, positive forward diastolic flow in your MCA. So there's either no PDA or else a PDA that's not hemodynamically significant. It's not exerting a very negative impact. Panel B is showing that there's absent forward diastolic flow in the MCA. And C, you can see here, there's actually reverse diastolic flow in the celiac artery. And so this is showing you that if it's a situation with panel B or panel C, that it's at least a moderate, if not a severe, hemodynamically significant PDA that's exerting negative impact on the blood flow and supply of oxygen to the brain. So in summary, our markers of systemic hypoperfusion, the main ones that we look at are going to be our descending aortic flow, our celiac artery flow, and our middle cerebral artery flow. We have several markers of pulmonary overcirculation. So we can assess the left atrial to aortic root ratio. We can assess the left ventricular end diastolic diameter. I didn't mention it here because we don't typically use it in clinical practice, but you can look at pulmonary vein peak systolic and diastolic velocities, our mitral E and A velocities, the EA ratio, the isovolemic relaxation time, left ventricular output, the left pulmonary artery systolic and diastolic velocity, as well as assessing the atrial communication characteristics. And then, of course, the PDA characteristics themselves, such as the architecture of the PDA diameter, and the color and pulse wave Doppler flow patterns. So all of what I've said up until now is not particularly controversial, but this is where things start to get a little bit more controversial. And all of you are trainees in hemodynamics, so I'm sure you fully appreciate that the PDA is a controversial topic and that there's many, many studies and reviews and documentation on. And I'm just going to summarize and touch on these topics quite briefly. So how do we ascribe significance to a PDA? So clinically, first of all, clinically, what's our cardiac exam? Is there a murmur, a wide pulse pressure, a low diastolic blood pressure? Do we have any signs or symptoms of pulmonary overcirculation like ventilator dependency, high oxygen requirements, pulmonary edema on a chest x-ray, or even pulmonary hemorrhage? And then do we have any signs or symptoms of systemic hypoperfusion, such as high creatinines, acute kidney injuries, lactates, intraventricular hemorrhage, or any abdominal concerns? Of course, if we have access to echo, we can go through all of the characteristics on echo that I've just described. And there's also evolving modalities such as NIRS, which might come more into clinical practice over time. But there is no consensus agreement on the definition of what constitutes a hemodynamically significant PDA. And this is because the PDA is not a dichotomous entity, and that's a very important point to understand. The PDA exists on a spectrum. So there could be situations in which a PDA is beneficial. For example, if a baby is in acute pulmonary hypertension, you might want that PDA wide open to act as a pop-off valve to support your right ventricular function. It could be a neutral bystander. You know, it's there, it's present, but it's not exerting any hemodynamic consequences on the patient. Or it could actually be on the other end of the spectrum where it actually is causing some harm to the baby. Potential harm could be the signs and symptoms of pulmonary overcirculation that I described, or signs and symptoms of systemic hypoperfusion. So it's really important to understand that the PDA is not black and white. It's not good or bad. It's somewhere on the spectrum, and that spectrum will be influenced by so many characteristics such as the gestational age, the birth weight, the genetics of the patient, the antenatal history, the current clinical state of the patient, etc. Some situations that it might be beneficial for you to have a PDA could be congenital heart disease. We're all aware of duct-dependent lesions in which it's critical that the PDA stays open, and we use Prostin to support that. Acute pulmonary hypertension, in which could arise from any number of things. It could be part of a congenital diaphragmatic hernia picture. It could be a meconium aspiration, a HIE, a baby with Down syndrome, etc. In an acute pulmonary hypertension picture, you might want the PDA open, as I mentioned, to act as a pop-off valve for your right ventricle. Or if the baby is in right ventricular failure for any reason, the PDA might be beneficial too. And then obviously, as I mentioned already, there could be situations in which it's harmful, in which it's causing pulmonary overcirculation or systemic hypoperfusion. And then, as you can appreciate, there could be a myriad of situations and circumstances that exist somewhere along those two ends of the spectrum. Importantly, when you're assessing the literature, there is considerable variability in the specific criteria and cutoff values utilized in PDA trials. So as you start to delve more and more into this topic, that becomes more relevant. How do they define what a hemodynamically significant PDA was, and what was their enrollment criteria for their trial? And hemodynamic significance, as I alluded to earlier, is a lot more than just a diameter measurement. You have to do a holistic assessment. What's the antenatal and maternal history involved? What's the clinical course to date? And what's our current exam? And of course, if you have access to echo, what signs and symptoms are we seeing on our echo that support our clinical picture? And PDA scores are becoming more commonly utilized, and they do help provide us with a more objective assessment of hemodynamic significance that can be helpful clinically too. So PDA scoring systems, there are a few, and they can be used to assign significance and help guide your treatment decisions. There are a number out there. So this is a group between Chicago and Cleveland. They've just published their PDA score in 2022. There's a PDA Iowa score, and the score that Afif El-Kafash developed along with Patrick and others, which is the one that we use in the Rotunda Hospital in Dublin. This score, I believe this paper was published in 2015. They studied 141 infants with a mean gestational age of 26 weeks and a mean birth weight of 952 grams. And when they looked at these patients, they saw that 5 variables were identified that were independently associated with chronic lung disease or death before discharge from a PDA. So they were gestation at birth, PDA diameter, excuse me, the maximum flow velocity, the left ventricular output, and the left ventricular A wave on tissue Doppler assessment. And they saw that a PDA score of 5 or above had a sensitivity and a specificity of 92 and 87% at predicting chronic lung disease or death from a PDA. So this score so far is the only one that has been validated. And myself and my colleague Rachel Mullally, we wanted to assess the accuracy of using the score versus just using a diameter. We had a standard way of measuring the diameter, and what we saw was that there was a much greater spread in the measurements of PDA diameter alone versus utilizing the PDA severity score. So it's telling us that across users, the PDA severity score is a much more accurate way of assessing the hemodynamic significance as opposed to just using a PDA diameter alone. And that in itself will also have treatment implications, especially when you're working in a department where maybe more than one person performs echo. I'm very briefly touching on approaches to PDA medical management. It's not really the focus of the talk, but just to inform the trainees that there historically has been three main approaches to how to manage a PDA medically. There was a prophylactic approach, but there was three major problems with this, which I'll discuss in a second. The prophylactic approach was largely superseded with either a more targeted approach or a conservative approach. And different departments will use different approaches based off their own experiences and opinions with regards to PDA. And obviously the prophylactic and the conservative exist on opposite ends of the spectrum. And targeted is in the middle. So with regards to the prophylactic approach, that approach aims to treat the PDA within the first 24 hours after delivery and typically without an echo assessment and regardless of its hemodynamic significance. But obviously this can present problems. If you are not performing the echo, the baby might have undiagnosed congenital heart disease and a duct-dependent lesion that you may not want to treat, obviously with an NSAID or paracetamol. If the baby actually hadn't fully transitioned and there was either systemic or suprasystemic pulmonary pressures, that might not be a good idea to administer prophylactic medical therapy to that patient. And equally, if you're not making an attempt to assess the hemodynamic significance of that PDA, you might be exposing babies with low risk PDAs to medication that they don't need. And we know that NSAIDs have side effects, such as thrombocytopenia, a link with necrotizing enterocolitis, and AKI. So for these main reasons, the prophylactic approach has largely fallen out of favor. The conservative approach on the other end of the spectrum, the aim of this is to ameliorate the effects of left to right shunting without pharmacological or surgical intervention. And there are a number of ways that people may try and do this. They might try and fluid restrict the patient, which, you know, if you're reducing PN, etc., could have impact on the patient's growth and electrolytes. Utilizing diuretics to try and combat the pulmonary overcirculation and pulmonary edema. Using high PEEPs, either on non-invasive ventilation or on, you know, when they're intubated, utilizing permissive hypercapnia or running high hematocrits. The running high hematocrits was something inherited from children with congenital heart disease. And I've written a review on this a few years ago, and really there's not a strong evidence base for utilizing any of these strategies. The targeted approach is now what I would assume most units adopt. And this is where they are making an attempt to identify high-risk babies at risk of consequences of a left to right shunt, and then utilizing a score or another system, be that clinical or echocardiographic or a diameter measurement, to dictate what patients they deem as high risk and treating those patients and not treating the patients that they deem low risk. So obviously you're trying to better target your medical management to those in greatest need and not expose babies to medications or therapies that are low risk that you don't think need to be exposed to those interventions. So there already is evolving evidence-based supporting such as a targeted strategy. This is work that's come out of the Iowa group. So this publication in 2023 looked at the impact of early hemodynamic screening in babies born at 22 and 23 weeks gestation, either with a hemodynamically significant PDA or died over the first week of age, and compared them to a historical cohort. So there was the hemodynamic screening epoch, where these babies had an echo between 12 to 28 hours of age, and their PDA treatment was based off that echo assessment. And this group was compared to a historical epoch where the echo was performed at the discretion of the treating physicians. So in the hemodynamic screening epoch, they found that targeted PDA management showed a twofold reduction in the composite primary outcome of death prior to 36 weeks or severe BPD. They showed lower severe IVH, lower neck, lower use of vasopressors, and an increase in survivor-free of severe morbidity from 50 to 73% among neonates less than 24 weeks gestation. Moving on to what determines if a PDA is going to close. There's a lot of things that are going to influence if your medical therapy is going to be effective and if the PDA is going to close if you administer an NSAID or paracetamol. Looking at all the literature, approximately half of the babies that we treat with medical therapy will close their PDA. And it's going to be influenced by a lot of different factors. It's going to be influenced by the timing of administration. It's generally understood that the earlier medical management is given, the higher the likelihood you are of treatment success. The route of administration, so we can give it IV, we can give it oral, we can give it rectal. And there's evolving evidence base that oral might be the most effective, or looks like it could be the most effective, because the concept behind that is that if the medication has to pass through the gut, it's entering the bloodstream in a more steady state, as opposed to us bolusing with IV medication. So that's definitely an area of active research. The dose obviously will influence your chances of success. Again, there's more evidence coming out that higher dose ibuprofen is more successful than regular dose ibuprofen. The frequency of the administration, if the baby's received a full course, because obviously sometimes medication therapies are stopped early. If there's abdominal concerns with an NSAID or an AKI, medication therapy courses might be stopped early. When it's given, so as I said, the timing is very important. If you give it kind of day 2 or 3, it's thought that you have a better chance of success as opposed to waiting until day 7 to 10. And then the individual pharmacodynamics and pharmacokinetics of the patients. With regards to the evidence base, there's been several Cochrane reviews looking at different combinations of medications and the route of administration. This Cochrane review showed that ibuprofen is as effective as indomethacin in closing a PDA, but ibuprofen had less side effects. It had ibuprofen use reduced the risk of neck and transient renal insufficiency. And orogastric administration of ibuprofen appears to be as effective as IV administration, beg your pardon. This Cochrane review showed that oral ibuprofen appears to be more effective in PDA closure than IV ibuprofen. And then looking at the comparative study of the efficacy and safety of paracetamol, ibuprofen, and indomethacin, this group assigned their neonates randomly in a ratio of 1 to 1 to 1 to oral indomethacin, oral ibuprofen, or IV paracetamol, and they found no significant difference in PDA closure amongst those 3 treatment groups after completion of 2 courses of treatment. And with regard to, again, there's a lot of literature on what predicts the chances of closure. This particular study looked at what predictors of successful PDA closure with acetaminophen in premature babies. They had 66 infants, and they found that the success was associated with a gestational age over 26 weeks, birth weight over 750 grams, and a PDA size less than 0.2 centimeters. But there's a lot of literature out there. And then just one slide on if we have decided to treat a PDA medically and we're not successful, where do we go from there? So if it's still a problem, perhaps PDA ligation or device closure could be considered. And some institutions do use specific criteria to help ascertain the urgency and who should go for device closure. And again, this is another area that we need for further research on. So I'll stop there for any questions. Hopefully that was helpful, and I'd look forward to any discussion and questions.
Great. Thank you so much, Ashley. That was a great talk.